I'd like to welcome everyone. My name is Rebecca Armstrong. Thank you for joining us for today's webinar on the advancements in care for metastatic breast cancer. I am the manager of the patient education programs for the Canadian Breast Cancer Network. Before we get started, I'd like to cover a few housekeeping items. The session is being recorded and will be available on our website for anyone who may have missed it. I'll send out a link once the recording is available. You'll also find previously recorded webinars on our website that address a variety of different topics related to breast cancer. I'd like to extend our sincere appreciation to our sponsors for the session today, who have provided support through unrestricted educational grants. Novartis, our gold level sponsor, AstraZeneca and Pfizer, our silver level sponsors, and Seagen, Merck, and Roche, our bronze level sponsors. I would like to now welcome our host for the session. The format for the session will include a presentation by our expert speaker, followed by a question and answer period. Please feel free to submit your questions throughout the session using the Q&A function that you'll find at the bottom of the screen. So now I'd like to welcome our host, Kathy Amendolia. She's the chair of the board for the Canadian Breast Cancer Network, and she has personally experienced a breast cancer diagnosis. Over to you, Kathy.
Okay, thank you, Rebecca, and welcome again, everyone. Thank you for joining us today. I'm pleased to welcome and introduce our expert speaker, Dr. Karen Gelmon. She's a professor of medicine at the University of British Columbia and a medical oncologist at BC Cancer Agency in Vancouver. We are also very lucky to have Dr. Gelmon serve as a member of the Canadian Breast Cancer Network's Medical Advisory Board. We are incredibly appreciative of all the time that Dr. Gelmon offers to the patient community by joining us today. Dr. Gelmon, great to see you again, and thank you for being here today.
Thank you very much, Rebecca and Kathy, and I'm pleased to be here. So I've been asked to talk about advancements in advanced or metastatic breast cancer. Either term can be used interchangeably, and they're both used. I'm going to be presenting some slides, and it's always a question because I know many of you know a lot about breast cancer and some of you know less. It's a question of what we present. So I'm going to try to present some broad concepts of how we approach advanced or metastatic breast cancer. I'm going to mention some advances, and then I'm going to hopefully have a lot of time for questions because I think your questions are often the most important. So with this, I'm going to try to share my screen. Do you guys see my screen now?
Yes, we do.
Okay, great. So here are my credentials, and I'm speaking to you from the lands of the Salish people, the Salish, the Musqueam, and the Saulteaux, and I'm pleased to be here in what is known as Vancouver to present this to you. So let's first talk about the spectrum of treatment for the patient. Excuse me. We know that ideally what we want to do is prevent cancer. We want to have cancer prevention and a healthy lifestyle. And living in Vancouver, the majority of patients I see say, I've been very healthy, I'm vegan, I exercise, I don't smoke, I don't drink, and why did I get cancer? And although we know that a healthy lifestyle is important, we know that healthy lifestyle alone does not prevent breast cancer or other cancers. What one can see is cancer screening, cancer treatment, and then quality of life and survivorship down here. Now, this is a continuum. And what we're talking about today is really in that cancer treatment place, that place where it's advanced or metastatic disease, and we'll talk more about that, and going right through survivorship and end of life. What's important in this whole continuum is the well-being of the patient. And one of the most important things is we have to support the patient journey. And how can we support that? One of the ways is by providing information and access. So all of you attending today is important in terms of increasing the information level of everybody. What's important is that, it just doesn't want to move ahead. Let's see if my screen won't move ahead. Oh, there we go. That one of the things that we've learned over the last few years is in this whole continuum, what's most important are patient-related outcomes. They're a prime concern for care and clinical trials. So what does that mean? It doesn't matter how good a clinical trial looks. It doesn't matter what an oncologist says. What's most important is, how does that feel for the patient? Now it's taking a while for, oh, there it goes. Now, what do I mean by that? One of the things we have to know is that when we measure success in cancer treatment, what success means might be different to different people. So the oncologist talks about progression-free survival, overall survival and response rate. What does that mean? Progression-free survival is the time that somebody is on a treatment where their disease does not grow. Response rate means, does the cancer shrink? And survival is, how long is a person living? The duration of effective treatment. If you've got a treatment that's effective, but it only lasts a few weeks, is that worthwhile to the patient? Or do you want a treatment that lasts for months or years? And one of the other things that's really important, and this is becoming an increased problem, is access to appropriate therapy. Success to your family doctor, your primary care, might be supporting the patient, having good quality survival, and knowing from the oncologist and from the patient what the outcome goals are. But what's success to the patient? What's success to the person living with the cancer? The biggest success for somebody living with advanced breast cancer is to not have symptoms, to not be feeling sick, to have an improvement in quality of life. And quality of life may be different definition for different people at different times, and also may change as time goes. So when somebody gets diagnosed with advanced breast cancer right off and has disease in their bones, but their bones aren't hurting, they want to be able to still ski or still hike or still go to the cottage or what have you. It might be that a few years later, when their disease has progressed, their quality of life might be being able to have a nice visit with their family. So quality of life is a moving term. What a patient wants is increased duration of survival with good quality of life. So survival, if you're feeling crummy, most persons say that isn't what they want. They want survival to be longer with good quality of life. They want a treatment that doesn't have very many side effects. They want to feel they have hope and continued options for treatment. And they want to feel safe, respected, and they want their family to feel safe and respected. And that's something, as healthcare providers, we always have to keep in mind. So these are really the treatment algorithms, and this may seem simplistic to some of you, but I think it's worth going over. When we first diagnose a cancer, an early cancer, what are we trying to decide? We know that an early cancer, stage 1, 2, or 3 cancer, is potentially curative. Why do I use the word potential? We can't make guarantees, but our goal is to cure that cancer. What we're looking at is, what's the risk of that cancer? How big is the cancer? Is it a high-grade cancer? Is it in lymph nodes? And what's its chance of response? So if it's a small cancer that's estrogen positive, we might just give hormone treatment. If it's a large triple negative cancer or a large ER positive, we might give chemo plus maybe endocrine therapy plus maybe immune therapy. And the whole goal is to cure. And what we're looking at is, what's the risk of the cancer and what's the response? This confuses lots of people because they're sitting in the waiting room and one woman is getting radiation only and the next woman's getting chemo and radiation and surgery. Why is it different? It's different because their cancers are different. If a cancer comes back, then what we're talking about is what we've just been saying: decreasing symptoms, improving survival, and maintaining quality of life. Now, one of the things that's hardest for people to understand, and again, this is pretty elementary, but I want to go over it, is that cancers are made of billions and billions of cells, and those cells can go from one place to another. They can go from the breast to the lymph nodes. We know about that with early breast cancer, but they can go in the blood system or in the lymphatic system around the body. So when somebody who's had breast cancer comes back 5, 6 years later with disease in their bones, and everything looks like breast cancer, and their doctor says it's breast cancer, they often say, "What are you talking about? This is bone cancer." No, it's breast cancer that's traveled to the bones. It's not a second cancer. Occasionally, people will have a second cancer, but the vast majority of times, it's breast cancer that's traveled to the bones or traveled to the brain or traveled to the liver or traveled to the lungs. We treat advanced breast cancer for these reasons. We don't expect cure. About 5% of persons with advanced breast cancer do get a cure, but that means that 95% of people don't. And therefore, it's wrong for us to promise a cure. We want to promise a good long life, but we can't promise a cure. I have one patient who's over 30 years since she was diagnosed with biopsy-proven lung metastases. Is she cured? She and I like to think she's cured, but do we know that for sure? I have another patient who had breast cancer, went to lungs, and it's never come back. She now, unfortunately, has an anal cancer, but do we know her breast cancer is cured? Probably it was, but we don't know for sure. I've put supportive care there, and supportive care has to come in all over. We're always trying to support the patient, but at some point, sometimes giving anti-cancer treatment that's directed to the cancer, may be futile, may cause more problems than benefit. So at that point, we might just be supporting pain, nutrition, shortness of breath, any of those things. So just to go over it again, our focus is on good quality of life, not just prolongation. It's always toxicity versus benefit. Treatments must be effective and tolerable, and ideally provide a survival benefit if possible, but providing good quality improvement in survival. And toxicity issues must be manageable. So a treatment that may be effective but is terrible toxicity is not a good treatment. This is the breast cancer classification, and I'm not going to go over this in great detail, except to say that when we go to the pathology lab, they talk about infiltrating ductal carcinoma or mammary carcinoma. That's about 65 to 75%. About 15% is lobular, tubular, mucinous are rarer. And then these are triple negative cancers called medullary, adenocystic, and metaplastic. When we look at the subtype is, are they estrogen positive or progesterone positive or HER2 positive? About 70 to 75% of breast cancers are estrogen positive. These are almost always estrogen positive. They're often HER2 negative. These infiltrating ductal can be ER positive or ER negative, HER2 positive or HER2 negative. And the medullary are almost always ER negative, HER2 negative, which is often called triple negative, which is a bad term. About 22 years ago now, there was a classification where they looked and called these ones basal-like, these ones luminal B, and these ones luminal A. And we talk about those, but they're not often used in the clinic. This is just what's called a circus plot. And a circus plot shows the DNA, which is the DNA is the building blocks of all cells, shows how confused they are. What you can see is a luminal A, which is often an ER positive, PR positive, HER2 negative, slow growing cancer. It doesn't have a lot of confusion. It's quite simple. As you go up to triple negative, it becomes more complex, and these are more complex tumors to treat. Now, an easier way to think about it is all breast cancers, about 65 to 75% are estrogen or progesterone positive. About 15 to 20% are HER2 positive. HER2 is a gene that we have in all of our cells of our body, and I'm going to give you some things that's more confusing in a minute, but in the late 80s, it was noticed that about 15 to 20% of breast cancers had too many copies of the HER2 gene, had too much HER2, and that's called HER2 overexpression. This is just what it looks like to the pathologist. So all those black cells are estrogen positive. All those brown rings are HER2 positive. Sorry, and the fish is looking at the chromosomes. And about 15 to 20% are triple negative. I really apologize. I've had this cold for a while. Now, what are we looking at here? The same three groups. What we're dividing them into is other markers here. The other markers are shown here. I'm going to be 1 second. 1 second. Apologies for that. I just went and took some good old Robitussin. So when we look at other biology, we have something called PDL1 here. We have BRCA1 and 2 mutations, which we know can occur in triple negative or hormone positive. We have a number of other things here. And what's this important about is that we're now developing drugs that specifically target these things. When you hear the term personalized medicine, this is what we're talking about. So you can see we've got BRCA, we've got drugs for that. PI3 kinase, AKT, we now have drugs for those. We're starting to develop HER3 drugs. We have TROP2 drugs I'm going to talk about. We're starting to develop drugs for ESR1. So very, very soon, what are we going to do? We're going to look at your tumor, and we're not going to just say it's HER2 positive, hormone positive, or triple negative. We're going to say, oh, you have a PIK3CA mutation. There may be some drugs that are good for you. Or you have an ESR1 mutation that you've developed. This is in the tumor from the beginning. This is something you develop. Well, we're going to give you drugs for that. We've been talking about personalized medicine now for years, but we're getting closer. We're very close. So I'm going to talk to you about something new, and it's confusing. So bear with me for a minute. I talked to you about HER2, and I told you that HER2 is in all of our cells. I told you that in the late 80s, it was described that about 15 to 20% of breast cancers are HER2 positive. And what happens with those HER2 positive is when the pathologist stains the core biopsy you've had, it comes out all brown, and we give it a score of 3+. Sometimes over the last 40 years now, we've given it a score of 2+, and then we do something called FISH, and we see, are there too many copies of the gene? And that 2+ plus FISH amplified was also called HER2 positive. Since the 90s, we've had drugs that are specific to HER2 cancers. And whereas HER2 cancers used to be very aggressive, we now have very good drugs for them. In the last few years, there have been some drugs developed that were initially developed for HER2 amplified or overexpressed cancers that we now are working in these, what we call HER2 low. So what does this mean? It means we've got HER2 in all of our cells. It means it's a continuum. So it's getting stronger here, it's 0 here, but there's some HER2 in HER2 1 and 2. And why is this important for you to know? This isn't totally prime time yet, but we now have drugs that for estrogen receptor positive or for triple negative cancers that aren't HER2 positive cancers, but are what we call HER2 low 1 or 2. We now have drugs that are targeting this that are helpful in the advanced setting. We don't use them in early breast cancer yet, but we're using them in the advanced setting. I'm giving you this little bit of information because this too is a way of the future. Just like I talked about ESR, PI3 kinase, BRCA is a way of the future. This is also a way of the future that actually is here now and starting to be used. What we know is that about 50 to 60% of all breast cancers are HER2 low. So when we got some of these new drugs, we thought they'd only be good for the 15 to 20% of breast cancers here, but it looks like they might be good for these drugs. Why is this also important? This is important because not just are oncologists learning new things all the time, but everybody has to be learning these new things all the time. Things that we were married to before, oh, this will only work in a HER2 positive cancer, are flowing by the wayside, and we're all learning new things and getting new treatments. It's an exciting time. So when we look at treatment algorithms for advanced breast cancer, we've got the ER/PR positive. Those often have a long disease-free interval. So it's often a long time from when somebody was diagnosed to when the cancer comes back. The prime treatment is endocrine treatment. And in first line, we usually give what are called CDK4/6 inhibitors, and we'll talk about those a bit. After CDK4/6 inhibitors, We're often using these PI3 kinase mutations. We've got a new AKT inhibitor that's very exciting. There's something called SERDs that are selective estrogen receptor degraders that work for those tumors that have something called ESR1. We've got PARP inhibitors if you've got a germline mutation. We've got the anti-HER2 therapy, and I'm not going to talk about that a lot today because it's a whole other talk. If people have bone metastases, they often get bisphosphonates like zoledronic acid, Zometa or denosumab. If they're ER negative, it's rapidly progressive, or if they've had endocrine therapy and it no longer works, cytotoxic or chemotherapy is often used. But now we've got something called ADCs, and we're going to talk a bit about ADCs. What are ADCs? ADCs are antibody drug conjugates. One of them is called TDXD or Enhertu, and one of them is called sacituzumab govitecan or Trodelvy. Now, it's the Enhertu, which is the drug that was initially used in anti-HER2 that's now starting to be used in HER2-low, as is the SG. We also have immunotherapy, and like in ER positives, we got PARP inhibitors. So this is a busy slide. Don't memorize it, but it gives you a little bit of an idea of how we think. When we look at how we treat people, there's an interplay. First of all, is it still ER positive? We often do a biopsy of the metastatic disease. How long have people been well? Have they had a long disease-free interval? How are they? What's their performance status? Performance status just means how well are you? If you're bedridden and have a very short survival, if you're young and it's due to the cancer, we're going to treat you. But if you're 95 and it's due to heart disease or something, maybe treatment isn't the right thing. How many treatments have you had? What are your prior responses? All of these things are looked at. Now, we've got improved outcomes with a number of different subtypes. There's a lot of improved survival for HER2 positives, for ER positives. There's less improvement with triple negatives, but we're getting there. However, I have to say, and I'm going to give this caveat because we always know this, some cancers are very resistant to treatment and remain incurable. And it's really, and aren't very treatable. I just was looking at an email before I came on from a patient of mine's husband who died about 10 days ago. And she had one of these cancers where it just didn't respond to anything. And even in 2023, we still have some of those cancers. But for the vast majority of cancers, we do have treatments. But as I said, advanced breast cancer, unless you're in that group of 4 to 5%, are not curable, but we can treat them. We can treat them like a chronic disease. One of the things to remember is heart disease isn't curable, but we can have people live for years and years and years with heart disease, but we need new treatments. So ER positive cancers, we've had a lot of improvements in survival, and the major improvements have come from what are called CDK4/6 inhibitors. One's called palbociclib or Ibrance. One's called ribociclib. There's also abemaciclib. And these drugs have been in the treatment now for quite a while, but they've really, really revolutionized things. What does that mean? It means that for somebody presenting with newly diagnosed advanced breast cancer that's estrogen receptor positive, whereas we used to just give them another hormone treatment. So if they'd been on tamoxifen, we might give them letrozole. If they'd been on letrozole, but it was a few years since they'd had it, we might give them letrozole again, or we might give them Faslodex. Now we're giving them treatment with a CDK4/6 inhibitor and a hormone. And these are really the results. So Paloma-2 randomized patients to either get palbociclib plus endocrine therapy or endocrine therapy alone. And this is what we call progression-free survival. How long does the tumor respond? And you can see that the cancers responded better with the upper line, which is the CDK4/6 inhibitor, than the lower line, which is just the hormone. This is Monarchs, the Monarch 3 and Monarch 7, both of them with ribociclib. Oh, sorry, here's Monarch 7, Monarch 2, Monarch 3, Monarch 7. These are all ribociclib, and what you can see is, again, progression-free survival. How long does the tumor stay in control is better with the combination than with the hormone alone. And these were looking at both aromatase inhibitors as well as Faslodex. These ribociclib trials have also had improvements in overall survival. So that's great. And that's what's really new in estrogen receptor positive cancer. And I'm not going to go through all the other things today because it's too much data. That's been the most important thing. Whereas people used to survive a median of 2 years or so, now it's up to 5 years or so or more. A median means it's in the middle. That means lots of people survive longer, lots of people survive less. But a lot of people are on these drugs for 5 years or so, which is way better than it used to be. Triple negative, as I said, is a hard one to treat. And the biggest thing that's happened in triple negative in the last few years is recognizing that immunotherapy is helpful. This was a trial called Keynote 355. What it looked at was giving chemotherapy plus a drug called Pembro. Pembro is used in melanoma, lung cancer, kidney cancers, lots of cancers, versus giving chemotherapy plus placebo. And what it showed was, again, this thing called progression-free survival, or how long does the cancer stay stable, was better for those people that got Pembro plus chemo. They then looked at the tumors. Which ones were more immune than others? And they came up with a score, something called CPS 0, less than 1, or CPS 10. And CPS greater than 10 showed a significant benefit of about a 4-month improvement if you gave the Pembro. What's our standard treatment in Canada now? In triple negative cancers, we check to see whether tumors are PD-L1 positive or not. And if there's a CPS score of greater than 10, chemo plus pembrolizumab is our standard treatment. What's important to know is the chemo is given usually for 6 or 8 treatments. And if someone's responding, then they're just kept on the Pembro indefinitely until the cancer starts growing. Now, I talked to you about ADCs. What's an ADC? An ADC, as I said, is an antibody drug conjugate. And I had a whole bunch of slides in, and I thought, oh, you don't need all those slides. I could do it from this one slide. So this thing that looks sort of like a Y, that's an antibody. And antibodies look like that. Now, antibodies have 2 aspects to them. They have the short part and the long part. And what happens is they glom on. Antibodies glom onto what's called antigens. Antigens are often proteins that they glom onto. So when you talk about antibodies for viruses or for anything, it's the same. What's been in development for a long, long time are antibodies for the treatment of cancer. And trastuzumab, or Herceptin, is an antibody that looks like this kind of Y part that attaches to the HER2 and is effective. What's happened is, over the years, people have tried to attach chemos to antibodies, and they've finally become very successful. What they're able to do is to attach a chemo to the antibody. And the most important part of this is there's now something called a linker. What's the linker? The linker is like the glue. The linker is the glue that attaches the chemo to the antibody. And what's important about the linker, and this technology really became important about, close to 20 years ago. It was really difficult to do before then. But what's really important is the linker now is more sensitive and knows when to let go, knows when to let go of the chemo. So Trodelvy, or SG as we call it, or sacituzumab govitecan, is an antibody to something called TROP2. TROP2 is on about 90% of breast cancer cells. The payload, what's the payload? The payload is the chemo, is what's called a camptothecin. And it's a drug called irinotecan, which is actually a drug that is used in colorectal cancers. And then there's this linker. And what was found when they developed this drug called Trodelvy is when they gave it to multiply treated people who'd had 3, 4, 5 treatments for triple negative cancer, compared to the chemo that was called physician's choice. So this could have been capecitabine or eribulin or whatever the physician wanted to give you. When you gave it the sacituzumab compared, you can see that there was 4 months better improvement in progression-free survival, and also a 5.4-month improvement in overall survival. So what's new in triple negative, as well as the immunotherapy? SG is approved in breast cancer in Canada for triple negative advanced cancer. It's now given after a prior chemo, but there's trials going on to see if it should be given earlier. What also is important is to realize that this kind of drug gets all around the body, and that's what's important. Now, I told you, and I'm almost finished now, I told you about the HER2 story. The HER2 story really was revolutionized by a drug called TDXD, or you may have heard of it called Enhertu. Enhertu is a drug that is a drug called deruxtecan that's attached to our old friend trastuzumab, or Herceptin. Herceptin's been approved in the treatment of advanced breast cancer in Canada since 1998. When they attached deruxtecan to trastuzumab, they found it was really effective in HER2-positive cancers. But this study that was reported by Shanu Modi, she works in Memorial Sloan Kettering in New York, but it's important to know that she's from Edmonton, so she's a Canadian. This was in hormone-positive patients. Hormone-positive patients had an improvement in survival when they got this, what we thought was an anti-HER2 treatment, compared to physician's choice. And this relates to what I told you about HER2 low, HER2 1 or 2 plus. These weren't HER2 overexpressing. These weren't patients we would have called HER2 positive. These were hormone positive patients with HER2 low. This has revolutionized how we're treating estrogen receptor positive cancers. And HER2, or TDXD, is now approved after a chemotherapy in hormone positive breast cancers in Canada. It's being looked at in earlier lines. There's a Destiny 06 trial going on, so we might even start giving it earlier, and it's being looked at in earlier breast cancer, and it's also this drug used in HER2 positive. Finally, I want to talk about PARP inhibitors. PARP inhibitors are drugs that have been around for a while. They're for that percentage of people who have BRCA positive cancers. It's only about 5% of patients overall who have BRCA positive cancers, but in metastatic disease, it might be higher. And we know that both olaparib and talazoparib, another one, it's not licensed in Canada, but olaparib can improve things. So it's important that patients with advanced cancer get checked to see whether they have a germline mutation or not. What are the new directions? I'm only giving you a really brief overview, but what I wanted to highlight was there are new drugs out there in Canada for cancer patients. There aren't enough new drugs out there yet, but they're coming, and we are moving along. The most important thing is we have to understand resistance. Why didn't that patient I told you about respond to anything? How can we define that? We have to understand when we can use immunotherapy. Should we use immunotherapy in early breast cancer? We are using it. We have to understand whether we can detect residual cancers by a blood test. Can we detect residual cancers by a blood test? And if we do that blood test, is that going to be helpful? And we also understand more about tumor heterogeneity. What is tumor heterogeneity? It's the fact that a cancer isn't made up of just one population. So just to show this is work that my colleague Sam Aparicio did. At diagnosis, your tumor might look like this. It might have a bunch of different types of cells. So these might be the redheads, these might be the brunettes, these might be the blondes, these might be the gray. Post-treatment, it might look different. And when it metastasizes, it might look different still. These cells don't look anything like that. This cell still looks like the right one. So we kind of have to know, what are we treating? Because we know that there's something called clonal evolution. That means that cancers can change in what they're made up of. So this is just one slide to talk about a liquid biopsy. This is when we take blood from you and look to see whether we can see cancer cells. This is still a work in progress. We don't know yet if everyone with advanced disease has this in their blood, but what we do know is when we can find tumor in the blood, tumor cells in the blood or circulating DNA, we can sometimes look to see if you have those mutations we talked about earlier, things like the PI3 kinase. So in summary, outcomes have improved remarkably. Majority of breast cancer are cured, but more people, however, there are people relapsing and dying, and those are the people with advanced or metastatic disease. And we need new interventions, both upfront for prevention, for diagnosis, for treatment, and for advanced breast cancer. So thank you very much for your attention, and I'm really happy to take questions now.
Great. That was fantastic. Thank you, Dr. Gelman. Fabulous presentation. You know, the good part about your presentation is that although it is scientific, you know, when you're diagnosed with cancer, it retains in your head, but to actually see a visual of what it might look like and what is, you know, what is what in all the definitions that are provided to the patient, that really helps a lot. Even though we can't, as the general population, retain all that information the same way a scientific person would, but it still gives a little more clarity, and you feel like you know that disease better than it just sitting in your brain. So I really appreciate that.
Thank you, Kathy. And sorry it was a bit of a whirlwind, but hopefully
No.
I covered some topics that are good for you.
I think that's great. So I'm going to start off with a few little questions that I picked up along the way. So your algorithm on the second slide, you discussed. So I'm going to bring it at a level where I understand people might want to have, you know, some questions around what you presented. So you said your little graph shows that the early breast cancers risk versus response, and then you put curative. So what I'd like you to further explain is curative in that area. What does curative mean to an oncologist, like as your?
Yeah. So in early breast cancer, I want cure. What I want by cure is I want that cancer never to come back. So I want to see somebody and they might have a 2-centimeter tumor not in their lymph nodes, or they might have a 5-centimeter tumor in their lymph nodes. What I want to be able to do is give them treatment that's going to mean that that cancer never comes back. Now we know what is the risk of the cancer. The cancer's risk is that some cells from that primary tumor have floated off. Even if it wasn't in the lymph node under the armpit, has it gone into the blood system? And is it going to come back later in the liver, lungs, or brain or whatever? Why we give chemo or hormones or immune therapy is to try to kill any of those cancer cells that are out there. Why we give any of these treatments that go all around the body. If there wasn't that risk of the cancer going elsewhere, we would just do the surgery or we would just do the radiation that's local. But we give those systemic treatments to try to keep those from coming back. Now, some people are cured just with the chemo, with the surgery and the radiation, but we don't yet know who that is. So for the vast majority of people, we give them a hormone or we give them a chemo or we give them something or anti-HER2 therapy. And what I want is I want that treatment to kill off any of those cancer cells that are out there so that that woman lives to be 98 years old and never deals with breast cancer again. So by cure, I mean never again.
Right. And what is the span of that age, like that population? What is the longevity of people who have been diagnosed and are now living or have lived a long life after diagnosis?
That's a good question. So with triple negative breast cancers, cancers that are estrogen, progesterone, and HER2 negative, if they don't come back around the body within the first 5 years, it's extremely unlikely they're going to come back. I've seen a couple people, so it's not a never, never. Nothing's a never, never in this world, but it's extremely unlikely. The thing with some people with triple negatives is some of those people are at a risk of getting another cancer, particularly if they have like a germline mutation or something like that. If it's an estrogen receptor positive cancer, they're sneakier and they can come back a long, long time later. So 50% of them will come back within the first 5 years, but that means that 50% will come back after 5 years. The longest I've ever seen somebody was 40 years, but I have seen some people at 20 years. So I'd love to be able to say to someone out there, oh, you're fine, no problem. If somebody comes to me at 11 years and says, will my cancer come back? And they've had a stage 2 ER positive breast cancer, I'll say that they're on the trajectory where the likelihood is getting less and less and less that it'll come back. But it'd be wrong for us to say it'll never come back.
Right, right. Okay. Now,
But I think people can have two, sorry, I'm going to interrupt. I think
Yeah.
people can sort of two files open. We'll use computers. One file open says, it'll never come back. I'm going to take out long-term subscriptions. I'm going to see my grandchildren. I'm going to live a long life. I'm going to live life like it's never going to come back. And the other file has to also be open saying it could come back. So because of that, I'm going to live life fully and I'm going to do everything I want now.
course.
So I think you need to have two files open.
Yeah, you can live with that in mind all the rest of your life, if hopefully that's going to be the case for a lot of people. So in terms of legacy patients, we call them legacy patients with the long, the longer lived patient. Where is the medical community and research in starting to test them after a certain period of time, meaning genetic testing, and then perhaps putting them back on if they're, let's say they're ER positive. Is there a mindset to reintroduce putting them on tamoxifen, or is that something that is being looked into?
So what we do know is that we are doing longer therapies in some people. So certainly it's no longer just 5 years. A lot of people with node positives or early cancer or disease in their that's large, a lot of those people get offered 7 or 10 years of treatment. We have looked at longer, and most people aren't giving longer. So, but the upfront, we haven't looked at stopping and then starting again. One of the questions we're going to come up with is right now, and I really, really want to say right now, circulating tumor DNA is not there yet, but it might be in the future. So nobody, please, nobody from this webinar goes out and spends $5,000 on a circulating tumor DNA right now. But it might be that a few years from now, it will be worthwhile buying one and seeing, because if somebody then does have evidence, let's say they're 7 years out from a diagnosis, they really want to stop their letrozole. Let's say they do a tumor DNA and they find that they do have circulating tumor DNA. We don't know yet if starting letrozole again or doing a new SERD or doing a new treatment would make a difference. But those are the studies we're going to be doing at that time. So today we're not there. Don't do your circulating tumor DNA today. But I think we will be there later. A number of years ago, people thought PET scans were going to be the answer, that, you went out and you got a PET scan. They're not the answer, but it might be that in the future, we'll have a blood test.
Great. And just to wrap this area up, what about that 4 to 5% who fall in the curative state in the metastatic?
Yeah, they are blessed. They're lucky, and I think, what are they usually? They're usually well when they start. They usually have what we call oligometastatic disease, so minimal amounts of disease, not disease in lungs, liver, brain, everywhere, but a little small amount of disease that has responded remarkably to treatment. My guess is we're going to see that number increase. In the TDXD studies, the Enhertu studies, there have been some what we call complete responses. Now we've got to wait longer. We need to have a duration to see if they ever come back. But my guess is that as we get better treatments, targeted treatments, that number is going to go up.
Good. Okay. And can you just explain ER/PR? Can you give us a little bit of a breakdown on that? Because it stops at ER for most conversations.
Yeah, so ER, estrogen receptor, PR is progesterone. Those are the two main hormones we have as women, and men have those hormones too. We know that there's different levels. Estrogen is up there more. Progesterone goes up around period of times and goes up with pregnancy and comes down. We know that when people feel bloated and unwell, that's often the progesterone. We know that cancer cells, about 70% of them have either ER or PR. Most of them have both estrogen positive and progesterone positive. Some of them have estrogen positive and progesterone negative. Those are more often a little bit more aggressive and are known as what we call luminal B. There's a very, very tiny number that are reported as estrogen negative, progesterone positive, and my pathologist says that means the pathologist made a mistake. So I don't think there are very many that are just progesterone positive. It's the estrogen that's more important. But what people think is they work in sync. So when there's an estrogen and a progesterone, they work in sync and they respond better to hormone therapy.
Great.
But that isn't to say that estrogen positive, progesterone negative don't respond. They respond well too.
Okay, good. So you touched on HER3. Can you dive into that a little bit more, please?
Sure. So we have HER1, HER2, HER3, HER4. It stops there, only 4. HER1 is also known as EGFR, and HER1 is very important in things like lung cancer. EGFR drugs are used in lung cancer. HER2 is the one that we know is important in breast cancer. What we know is these are called transmembrane ligands. That means they straddle the membrane of the cell. And in order to turn the cell on, which is what they do, they turn the cell on to rev it up and rev it up and rev it up and cause it to cause problems. That HER2 likes to either homodimerize, that means it connects with another HER2, or it heterodimerizes, it connects with a HER3. So HER3 we know is important. Pertuzumab or Perjeta, which is a drug we have, is a HER3 drug. And we know trastuzumab or Herceptin plus Perjeta work well together. Now, we now have some other new drugs and some ADCs that are targeting that HER3 directly. So it's still in the works. There aren't any other than the pertuzumab that are approved in Canada or anywhere yet, but those are in the works. And HER3, I think stay tuned, because now that we know HER2 is important, not just in HER2 overexpressed cancers, but in others, it might be that HER3 will also be important, but we don't have that data yet. That's a future.
Good. Okay. So I'm going to take live questions now to you. I have a question about inflammatory breast cancer.
Yep.
So the person writes that, they'd like more insights on the treatment for inflammatory breast cancer.
Okay, so just to say, I just gave a lecture. Just one question that I'm just going to really quickly go is, Juliet just asked that a new drug should be available soon, similar to Verzenio. It's actually ribociclib, and it's going to be for early breast cancer soon too. It's already approved in advanced breast cancer. So that's more of an early breast cancer, but it would be ribociclib that we're talking about there. So back to your question about inflammatory breast cancer. Inflammatory breast cancer is a rare type of cancer. It is a kind of cancer that presents with a red breast, often hot, often swollen. It's less than 5% of breast cancers. When it presents, it usually is quite dramatic. The breast is red, and it's often poorly diagnosed. There's often not a lump. Often a woman will go to a doctor and the doctor will say, oh, you've got mastitis, but this woman isn't breastfeeding, so why would she have mastitis? What is done is you get a biopsy, sometimes a biopsy of the skin, but even if the biopsy of the skin is negative, a deeper biopsy is important. A mammogram may show a mass, it may show just skin thickening. Inflammatory breast cancers are often very fast growing and aggressive. They're often HER2 positive or triple negative. They're treated exactly like any other cancer, but they're treated before surgery neoadjuvantly. So they're given, if they're triple negative, chemo plus pembrolizumab. If they're HER2 positive, they're giving chemo plus Herceptin plus pertuzumab. If they're ER positive, we don't know yet whether they should get chemo plus a CDK4/6 inhibitor or what, but they're treated like that. The goal is to cure them if they're just localized to the breast, but because they're often diagnosed late, about 25 to 30% of inflammatory breast cancers are already metastatic at the time of diagnosis.
Okay. Okay. And how do you determine the biology? Like if there isn't a tumor?
Well, you can do a biopsy of the skin or of the breast, and you'll get the same. You'll get cancer cells, and you can find the estrogen and progesterone, the HER2,
Great, thank you.
or of the lymph nodes.
And the lymph nodes. Okay.
Yeah.
Okay. So a question here is the person writes, patients who apply precision medicine properly live significantly longer with better quality of life. Why do we not get precision diagnoses, i.e. PET scans, liquid biopsy as a standard? Why do we wait for failure and change before treatment?
So just to say, I have to disagree. People with precision medicine don't always live longer and don't always have less toxicity. Precision medicine isn't there yet. So we have to go back. Early breast cancer, we may get more precise later. We may find out what are those resistant cells later. But right now in Canada, the vast majority of breast cancers, early breast cancers, are living and are being cured. Our treatments are working for those. And if you've got an early breast cancer that's a 1 centimeter estrogen receptor positive cancer, lobular cancer, it's not going to show up on a PET scan. It's not going to show up on circulating tumor DNA. So there's no reason to do it. If you've got a 2.5 centimeter with nodes positive, estrogen negative, HER2 positive cancer, yes, you should have a PET scan for staging. So it depends on who, but should you have circulating tumor cell? We don't know yet whether circulating tumor DNA is important. What we are doing is looking at studies that if you have neoadjuvant treatment and you still have circulating tumor DNA at the end, should you get more treatment, just like Kathy was alluding to earlier. Precision medicine for advanced breast cancer is important. So I agree with you there that we should be doing more PET scans if it's appropriate, but some cancers, like lobular breast cancer, doesn't show up on a PET scan. So it has to be the right kind of cancer. We should be looking for markers, as we talked about, estrogen, progesterone, HER2, PI3 kinase, immune markers, BRCA. Yes, I agree with you. We should be looking for those markers in advanced cancer. And we should be targeting our treatments to those. What's interesting, though, is although we keep talking about precision medicine, now we have some treatments that aren't really targeting that. So something like Enhertu or TDXD isn't really targeting the precision. It's HER2 1+ or HER2 2+, which is a much broader group than a precise precision. And what's also important to know is although TDXD, I've been saying it looks like a great drug, it's got some terrible toxicity. Some people have some extremely bad lung toxicity, and about 15% of people get lung toxicity. So precision medicine is good when it's used appropriately. I can only hope that it's going to get better and better and better. Drugs that are used in precision medicine sometimes are less toxic, but not always. Something like alpelisib, which is used for PI3 kinase mutations, which is precision medicine, often gives people diabetes. So we're not where we want to be yet. We want to have better and better treatments that are more precise and that are less toxic. We're headed in that direction. I wish I could tell you we are there now, but we're not quite there yet.
That's great. Thank you. So I'm going to go back to all these treatments, okay, for early and metastatic or advanced breast cancer. So it's always been in the mindset to have less treatment to be better quality of life. But is it changing in a better way, but we have more treatments being given to a patient? Like, what's the change? What's the most significant change in early breast cancer? Say a person with ER positive, small tumor, microscopic, signs of cancer in their lymph nodes, first lymph node, let's say, and they treated it back way when with everything. Has that changed in the treatment plan?
So that has changed a lot. What's changed a lot is that now, if it's a very, very estrogen receptor hormone sensitive cancer and it's small, we would do a genomic test, something called the Oncotype Recurrence Score, and we probably wouldn't give chemo. We probably give hormone therapy alone. Alternatively, if we saw a cancer that was maybe even 1.8 centimeters, but that had a high genomic score, we would give chemo, but we'd be able to tell the person there's a reason why we're giving you chemo. We're not just shooting from the hip. We're giving you chemo for a reason. So we are withdrawing therapy when we don't need it, and we are accelerating therapy. Likewise, we give more and more neoadjuvant chemo. So we give neoadjuvant chemo for, let's say, a HER2 positive stage 2 cancer. If indeed that cancer goes away completely, then we just continue on Herceptin. But if that cancer is still there at the time of surgery, then our standard in Canada is to give TDM1 now, and it might be in the future to give TDXD. So we are trying to, figure out how to withdraw where we don't need and how to continue.
Great. So I have another question from the audience. So are mutations tested right away at point of diagnosis, or will we have the opportunity to get tested as soon as possible so that we know our specific mutations? Patients say that when they're tested for BRCA, they're not sure if they're tested for anything else. So I guess there's a little bit of uncertainty of how these testings are applied and what information is gained by those.
So first of all, I think that's a great question, and thank you for asking it. There's two kinds of mutations. We have what are called germline mutations. Germline mutations are mutations we have in every cell of our body that we inherit either from our mother or from our father. Things like BRCA1 and 2, which are genes we all have, some people have changes in those genes, and some changes in the genes don't do anything. They allow the gene to function perfectly normally. But some changes in the gene are what we call changes that are pathogenic changes, which mean that the gene might be less effective in preventing cancers. We know that about 10% of persons with breast cancer have a germline mutation that may be related to the breast cancer. About half of those are BRCA1 and 2. There are other genes. There's something called PALB2. There's something called ATM, CHEK. There's the Lynch syndrome. There is P53 mutations with Li-Fraumeni. There's BRIP. There's a whole bunch of them. They're all much less common than BRCA1 and 2. If somebody has a risk of having a germline mutation, the best time to be treated is up front. The problem with that is there's a lot of people out there who are already diagnosed who didn't get offered that testing up front and who should actually think about turning up again. But who are the people at risk? The people at most risk are the people who were diagnosed early. And early is a different definition in different places. And Kathy and I were just in a meeting on Monday about this. In BC right now, young age is 35 and less. In Ontario, it's now 45 and less. If we look at what's called the NCCN guidelines, it used to be 50 and less, and now it's like 60 and less. But, younger than 50 is what we should be thinking about. So if you were diagnosed then, if you were diagnosed and you had a triple negative cancer, estrogen negative, progesterone negative, HER2 negative, at an age less than 60, or some people say at any age, you have a bit of a higher risk of having a germline mutation. So triple negative people should get tested. If you've got breast cancer, ovarian cancer, prostate cancer, pancreatic cancer in your family, and it's not that, oh, my grandmother on my father's side had breast cancer at age 80, and my aunt and my mother's side had breast cancer at age 70, it's got to be on the same side of the family. So if your grandmother had ovarian cancer and your dad had prostate cancer at age 52 and his brother had pancreatic cancer, you might want to look at that family. So it's lots of cancers at a young age that fit into the spectrum and that are on the same side of the family. And there are hereditary cancer programs in all of the provinces. You can go to their websites, you can look at that. So those are germline mutations. And to answer the final question, most places now are doing what we call panels. A panel might be 20 genes, it might be 45 genes, it might be 62 genes, it might be 90 genes. But most places are doing panels. So they're not just testing for BRCA1 or 2, they're testing a panel that has more. That's also important for what Kathy called legacy patients. So if you were tested for BRCA1 and 2 in 2005, you weren't tested with a panel, and going back now and getting retested might be important. Now, the other kind of mutations are what we call somatic. Somatic means body, but what it means here is tumor mutations. So we can have tumor mutations. In our tumors, we can have mutations. About 1 to 2% have BRCA mutations that are unrelated, but we can also have tumor mutations in other genes, like in AKT or PI3 kinase or ESR1. To test those, they have to test the tumor, and they have to test the tumor at the right time. Some of those mutations, as we talked about, evolve over time. So to test a new breast cancer patient for an ESR1 mutation doesn't make sense. The time to test for an ESR1 mutation is after somebody has had treatment with ribociclib and hormone treatment for 5 years. Then you test to see if their tumor has ESR1, because that might mean what drug you get. So those are tumor mutations. And sometimes those are tested in panels of a few different mutations. Sometimes those are tested individually. Sometimes those are tested in blood circulating tumor DNA, not in the tumor, but they come from the tumor. So there's two big kinds of genetic testing, and it's important we differentiate them.
Great. I'm going to continue with the questions, and I'm going to continue with the genomic testing. So this person asks, what are the options for genomic testing in Canada? I know the answer is huge. I know the answer is huge. In BC, if denied for POG, personalized oncogenomics, are there any options other than private pay for tumor sequencing after failing all approved lines of metastatic treatment? I don't know if you know the answer to that.
Yeah, so I do know the answer. So, first of all, I guess refused. POG is a small program and it accepts certain people. And I think what I would really do is, if you are somebody with advanced disease, ask your oncologist if they clearly have asked POG, and you can also go to the POG investigators, the POG nurse, and ask directly if you're eligible or not. So I think that's the first thing. Sometimes the problem with some breast cancer patients is they only have disease in their bones, and it's hard to do DNA sequencing on disease in the bones. So that's sometimes a problem. If indeed you're not eligible for a program, there's different programs in Ontario, there's different programs in Quebec, all across the country, then sometimes you're eligible for a trial. And sometimes within a trial, you can get your tumor sequenced for a trial to see if you're eligible. So that's the second thing. The third thing is private, and I hate to tell people to do private because it's expensive, but I think what you need to do is talk with your oncologist. Would there be a benefit in sequencing? One of the problems is that with breast cancer right now, there are a lot of treatments that aren't linked to that sequencing. So TDXD or Trodelvy or those things aren't linked to sequencing. So you can get those treatments without sequencing. There aren't as many treatments for breast cancer as, for example, lung cancer right now related to sequencing. I hope we get there soon, but there aren't as many. So you don't want to do sequencing just for the sake of doing sequencing and not have a treatment. There's, a very, very rare mutation that's got a drug that works really well. Well, in breast cancer, it's less than 1% of breast cancers have it. So you don't want to be spending $4,000, $5,000, $6,000 US to get sequencing if there's not a good reason. And again, if your oncologist can't answer it, then try to find an oncologist in an academic center that can give you a good answer to this. And there's lots of people working on this.
Great. So continuing with this, we don't have standard genomic profile for metastatic breast cancer, but you mentioned biopsy for a recurrent cancer. What are you looking for now, and how does this need to evolve with all these precision meds coming?
So the biopsy is, first of all, to say, is it breast cancer? Usually it is, and that's what I said. But, every so often you have somebody who's had a breast cancer and then has something in their liver and it's a colon cancer. So the first thing you want to know is what you're treating. Second thing you want to know is, although the breast cancer might have been estrogen receptor positive, HER2 negative. Now it might be estrogen receptor negative, HER2 positive. Tumors can evolve. So you want to know what you're treating. So although that might not seem like highfalutin precision medicine, it still is precise in that you want to treat the right kind. You want to give the drugs for the right tumor. So you might want a biopsy to make sure before you give an estrogen drug, it's still estrogen positive. The other thing you might want to look at is things like PI3 kinase, ESR1, AKT, those things that are coming along. So there are reasons. It's very true. We don't have a standardized onco panel, and there isn't a standardized onco panel internationally yet. It's coming, but it's not there yet. There are some centers that have standardized onco panels for breast cancer, but we're not there yet. But there are some things that can be looked at. And the very first thing is to say, well, is it estrogen positive? Is it HER2 positive? Then things like PI3 kinase, AKT, BRCA, ESR1, those are things to look at.
So with that in mind, what happens when that testing comes back in the gray zone, what they call gray zone, and then the physician has to discuss with the patient, you may or may not need chemotherapy, I don't know, it's not really clear. How do you, decide on what to do in this case?
So I think you look at the patient, you look at the patient preferences, you figure out if somebody, so I had a patient with a lobular cancer a number of years ago that was tested as ER negative. Lobular cancers aren't usually ER negative, but occasionally they are. When she came back with metastatic disease, it was in her bones. And it was quite aggressive, and she had a lot of pain and everything. We treated her with capecitabine because it was a chemo, but it was going to work. And she was on it for years, and it did a lot of good. But then it progressed. And what question was, I still thought, well, is this really an estrogen negative? So we re-biopsied it, and we did a technique where we were able to get more accurate estrogen positive, even though it was initially called estrogen receptor negative. And sure enough, she was estrogen positive. So then we put her on a CDK4/6 inhibitor and hormone therapy. And she really had very, very little response to that. But she wanted to try it. I wanted to try it. We thought, oh, this is a great other option. She's estrogen positive. But we also found she was PI3 kinase at that time. So after she didn't respond to the CDK4/6 inhibitor, we put her on a study of alpelisib, a study called BYLieve, and she was on that for close to 4 years with good response. So what are you doing? You're looking to try to find what that little piece of the puzzle is that will help. And then she progressed on that, and the only options were chemo. But working with the patient, she really wanted to know. She didn't mind undergoing another bone biopsy. I really wanted to know. I kept thinking we're missing something here. Although everyone's saying it's estrogen receptor negative, I feel like we're missing something. So I think it's us working as a team together. If somebody's got rapidly progressive disease and is short of breath and can't breathe, you might want to just jump in with chemo and then biopsy and see. If somebody's got a slow growing lung lesion, you might say, let's do a biopsy and see what this is. So I think it's working together. And in that gray zone, this was a gray zone because it was, lobular, but estrogen negative. It was gray. What was it really? Let's hedge our bets and figure out. But it's always got to be shared decision making.
Right. Rebecca, do you want to jump in with any questions that you're picking up on your end?
Sure. Just one second. Let me see what we've got.
She's gathered all the questions, so I don't want to miss any.
So someone is asking, in terms of TDXD and metastases, are there better outcomes for it based on metastatic site? Is it worth prescribing Enhertu to someone with lung mets, given a small risk for ILD, or should the patient start on a different ADC?
So that's a great question. Right now, it doesn't look, and I'm very sorry, my husband somehow has the eaves getting cleaned today. So I'm sorry about the sound in the back. What's really important to know is that right now it doesn't look like different sites. If somebody is well and has fewer sites, it often responds better than somebody who's very unwell and with lots of sites. Lung mets per se aren't a reason not to give it. There doesn't look like there's an increased risk of ILD if it's just normal lung mets. It doesn't look like there's an increased risk of ILD if you have asthma. It's more important in terms of general performance status and that. The most important thing with ILD is a patient being aware of it and being able to tell their doctor early on that they're having shortness of breath. Because if they are having shortness of breath, then a CT scan needs to happen. If it's ILD and it's grade 1, that means minimal, and we stop the drug and people respond and recover, we can try to treat again with the TDXT. But if it's ILD that's really severe ILD, we can't treat again. So that's why it's important that people tell their doctors, have CT scans and everything. So, it depends. Right now, as I said, TDXT is approved for second line. So people have had to have one line of chemo already and have had hormone therapy already, but it might come in earlier. We'll just have to see what their studies show.
Great.
Okay, thank you.
You have anything else, Rebecca, before I continue?
Yeah, I have one other question. I have metastatic triple negative breast cancer. My husband had prostate cancer in his 50s and is now metastatic. Regarding germline mutations, is it her kid or their kids who should get tested, or should they get tested?
So that's a really good question. It's usually better to test the person with the cancer. So if you've got triple negative cancer, is that what you said? You should be tested. If you've got triple negative cancer, right now, the criteria in some places is if 60 and younger should get tested, because that's a 10% chance of having a BRCA. In the NCCN, which is a North America, US guideline, it's everyone. I would get you tested. If you get tested and you're negative, then, your husband had prostate cancer, 53, that's young. I would look at his family. If he was the only one, then maybe not. But if there's breast, ovarian, pancreas, other prostate in his family, I would get him tested, but I would get you tested first. If you are positive, your children have a 50% chance of being positive, and they would have access to provincial testing free of charge. If you're negative, they're not going to have it from you, but that doesn't mean they couldn't have it from your husband. There is private testing. It usually costs about $200 to $300 US. But if you have triple negative cancer in all provinces in Canada, you should be eligible.
Yeah. Thank you, Rebecca. I'm going to move on to immunotherapy. So the person is asking, how does it work? Why isn't it offered to more people? Is it added to a patient's current treatment plan or given as its own line of therapy?
So immunotherapy. There's lots of different kinds of immunotherapy. I'm only going to talk about pembrolizumab and those immunotherapies because that's what's used in breast cancer right now. So what we call they're PD-L1 inhibitors. So what is it? Cancer cells, your own immune system has an ability to put up sort of shields against the cancer cell. So they puts up a shield against a cancer cell, and then the cancer cell can't be killed. So if you think about those shields as being called PD-L1 or PDL, what a PD-L1 inhibitor is it inhibits those shields going up. So it allows the chemo to kill the cancer. In breast cancer right now, pembrolizumab is used in two situations. One situation is in early breast cancer triple negative, stage 2 or 3, where it's given with chemo and then subsequently on its own in the neoadjuvant setting. So what does that mean? It's given before surgery with chemo to try to shrink down the tumor. So at the time of surgery, there's nothing left. And then usually it's given after the surgery for 6 months. The other place where pembrolizumab is used is, as I showed you, in triple negative cancer first-line treatment for those people who have what's called a CPS score of greater than 10, for those people who have an immune-like cancer. It's not given on its own. It really didn't show much on its own. It's given with chemotherapy. And usually that chemotherapy is carboplatin plus paclitaxel or Abraxane, or sometimes carboplatin plus gemcitabine. Those are the places. There was an exciting study shown two studies actually shown at ESMO, our European Society of Medical Oncology meeting in September, looking at giving immunotherapy in early high-risk estrogen receptor positive cancers. So people who had a grade 3, a rapidly growing estrogen receptor positive cancer that was big and in lymph nodes, and giving it neoadjuvantly. It didn't show anything yet in terms of decreasing events or improving survival, but it showed that more people had a better response. So I think we're going to see more of that in estrogen positive cancers, but it's not there yet. There was a drug called atezo that was used a few years ago, but it's no longer being developed in breast cancer. There are other immune drugs that are coming along, but they're not yet licensed. I hope that answers your question.
Yes, no, that's very good. That's very good. Is immunotherapy also given for BRCA patients?
No, a
No?
lap is a PARP, and a PARP is actually just against the BRCA, so it's not an immunotherapy. Having said that, there have been some studies looking at PARP plus immunotherapy showing benefit, but we're not there yet. But if you're a triple negative BRCA patient who's getting pembro plus chemotherapy, and you don't have a pathological complete response, you might be a candidate for olaparib plus immunotherapy.
They wouldn't start that at first line?
Yeah, that's in neoadjuvant, not in first line.
Okay,
Yeah.
okay,
Yeah.
okay. Okay, great, great, great. That gives us a lot of information about immunotherapy. I have a question here that this is we're going a little bit off the therapies. Is there data to speak of overall survival outcomes for younger diagnosed patients with de novo metastatic breast cancer versus an older person diagnosed with de novo? I would imagine survivorship issues are different, including quality of life.
So that's a great question. So de novo, so there's about 15% of people who present who are diagnosed with stage 4 cancer at diagnosis. That's more common, as I talked about, in inflammatory. That's also more common in HER2 positive cancers. I'm sorry if this is really loud. I wonder if I should move, or is it okay?
I think it's great.
Okay. So it's more common with HER2 positives, it's more common with inflammatory, but some people, even with estrogen receptor positive cancers, will be diagnosed with de novo. De novo cancers on the whole, when you look at stage 4 cancers, and when you look at trials of stage 4 cancers, people with de novo cancer seem to respond better than people who have had a recurrence. Why is that? That's usually because they've had prior treatment and they might have resistance to some of the prior treatments. So de novo cancers tend to do better. Likewise, younger people with de novo cancers tend to do better. It appears overall, probably because they have fewer comorbidities, fewer heart or lung or diabetes or other problems, because they can tolerate treatments better and because they're just more fit. Survivorship issues are very, very different. For somebody who's diagnosed with de novo stage 4 breast cancer and is young, fertility issues might be there. They might not have had their children and they're 38 and they've got stage 4 breast cancer. What about their fertility? Early menopause issues, job issues, friendship issues. They feel isolated. They sit in a treatment room with everybody who's age 70 and they're age 39. Marital issues, partner issues, all of those things can be very, very different. So I think that the supports we need for young persons with advanced disease are very different than the supports we need for persons who are older, but their outcomes are generally better. When you look at outcomes of people just getting diagnosed, the people who are very old and the people who are younger than 35 often do less well. People who are very old, it might be that they get a lack of substantial treatment. They might not get full treatment. People who are very young might have an aggressive cancer. The people from age 35 to sort of 75, though, generally do pretty well the same.
Okay, so we have a lot of questions. We're not going to get to them, obviously, right? But I think we covered a lot and your answers were fabulous. But I'm gonna let us go with one question that I have for you. Are you happy with the current state of where we're at with breast cancer in terms of treatments, success stories, pipeline stuff that's coming down for possible, treatments that we don't have now, but will make a huge change? Do you see anything that is, phenomenal coming?
So I've had a long career. When I started my career, persons with advanced breast cancer crumbled. I had young patients who couldn't get out of bed because their bones were snapping all over. Something as small as, when I was a resident, I remember seeing that. Something as what seems now small as bisphosphonates coming in made a huge difference, that people's bones were stronger. I have seen remarkable advances in my career, and I think we are doing so much better than we were. But am I happy? No, I'm not happy with where we're at yet. And a lot of the questions around precision medicine clearly demonstrate that we're not at precision medicine where we want it yet. We're getting closer, but we're not there yet. There still are too many people getting breast cancer, too many people recurring, too many people dying of the disease. I think we're in a much better place than we were a number of years ago. More people are getting cured with early breast cancer. I think we're in a better place because people are better educated and know what questions to ask. I think we're in a better place because I think most healthcare providers are doing shared decision-making, are understanding supportive care, are understanding quality of life. So that's all a better place. I think we're in a better place because we have more effective treatments and people are living longer and better with advanced disease. But we're not there yet. And, we can't sit back on our laurels yet. We're certainly not there yet, but it's way better. I think the things that I worry most about is access to care. In Canada, although it's not perfect, we're better than lots of parts of the world, even places like Australia have less access than we have. So we're better than lots of places, but I worry, how are we going to keep that up? How are we going to continue to afford it? We have to protect our healthcare system as much as we can so we can keep providing universal healthcare as much as we can. But I worry about the future of access to drugs. So there's lots of work to be done. We have to all keep working together. We're in a better place than we were, but we've got to keep working together. And I think education forums like this are really important to do that.
Thank you. Thank you. That's a great answer. And that's, I think, where we are all feeling right now. And we're going to continue to work together. That was phenomenal. Great session. So I'm going to finish off with my script because it's the standard thing to do. So I'd like to conclude our time for today's session. Thank you, everyone, for your questions and for joining us to learn about recent advancements in treatments, care, and research for metastatic breast cancer. Thank you, Dr. Gelmon, for being here with us today. It was fantastic. And thank you again to our sponsors, Novartis.
Oh, can I just say one thing?
Sure.
There's one question a grade 2, 1 centimeter ER positive, PR positive, HER2 negative is not an advanced cancer. Okay, just to that question. Sorry, I just had to answer. I'm so sorry.
No, that's fine.
No, that's not an advanced cancer. Talk to your doctor. Okay.
That's great. I'm sure the person who wrote that appreciated the answer. That's great. So
sorry, Kathy.
It's okay. I need to thank the sponsors. Novartis, AstraZeneca, Pfizer, Seagen, Merck, and Roche. Thank you to those sponsors. And following this session, you will get a link to complete a survey to provide feedback on this session. Please consider leaving feedback, as this really helps us improve future sessions for attendees like yourself. Thank you, everyone. Have a great evening.
Thank you.